Welcome back to the PTCB Prep Guide. Today, we are going to break down some of the highest yield cardiovascular and hematologic drugs you'll see from the top 200. We're talking brand, generic, what they're for, the major side effects, and that one-liner mechanism you absolutely need for the exam. It's going to be straightforward, fast, and focused, so you can lock it in your brain and remember it when it really counts. Let's get into it. All right, team, no messing around. Let's just get straight to it. Think of this as a rapid-fire review designed for maximum recall on exam day. We're going to lock these key drug facts into your memory. So these next few slides, they're basically your new digital flashcards. Okay, let's dive into our first and honestly our biggest category, blood pressure medications. These are everywhere, so you are definitely going to see them on the exam. We're hitting the 5 major classes you absolutely have to know. That's ACE inhibitors, ARBs, calcium channel blockers, beta blockers, and diuretics. We'll kick things off with how ACE inhibitors work, because they're a great place to start. So here's the core concept. It's actually a pretty simple pathway. Normally, you've got this enzyme called ACE, and its job is to turn angiotensin 1 into angiotensin 2. Now, angiotensin 2 is what squeezes your blood vessels and jacks up your blood pressure. ACE inhibitors, just like the name says, they get in there and they just block that enzyme. No conversion happens, the blood vessels stay nice and relaxed. That's vasodilation. And boom, blood pressure goes down. Simple as that.
Now zero in on that major ADR column. The absolute key takeaway, the thing you have to remember for ACE inhibitors is that annoying, persistent, dry cough. You see it right there for both enalapril and quinapril. If you see a test question about a patient on a BP med who suddenly has a dry cough, your brain has to scream, ACE inhibitor. It's a classic connection.
Next up, we've got the ARBs. You can think of them as the cousins of ACE inhibitors. They get you a similar result, lower blood pressure, but they just work a little later in the process. And here is the biggest difference. ARBs do not cause that dry cough. That's a huge distinction, and it's often why a doctor will switch a patient from an ACE to an ARB. But do notice they both share that risk of hyperkalemia, which is high potassium. All right, moving on to calcium channel blockers. Specifically, these two right here, verapamil and diltiazem, are called non-dihydropyridines. Now, don't let that big word trip you up. All it really means is they work more on the heart itself instead of the blood vessels way out in your body. And that little fact directly explains their main side effect, bradycardia, or a slow heart rate. They are literally slowing the heart down. Beta blockers are another class that slows the heart, so it's no surprise we see bradycardia pop up again as a side effect. But here's the critical difference you gotta spot. Bisoprolol is selective. It mainly targets beta-1 receptors, which are in the heart. Propranolol, on the other hand, is non-selective. That means it hits beta-1 and beta-2 receptors in the lungs, and that's exactly why it can cause bronchospasm and is a bad idea for patients with asthma. Diuretics, water pills, they help your body get rid of extra salt and water. For the PTCB, you absolutely must know what they do to your potassium levels. Thiazide-like diuretics, like indapamide and metolazone, make you lose potassium. That leads to hypokalemia. But look at amiloride. It's a potassium-sparing diuretic. It does the exact opposite, so the risk is hyperkalemia. That is a crucial distinction to memorize. Okay, let's shift gears. We're moving away from blood pressure and focusing more on the heart's electrical system and its pumping power. We're going to look at drugs for arrhythmias and heart failure, and you'll see how some ideas, like controlling heart rate, connect right back to what we just talked about. Okay, these are some heavy hitters for some really serious conditions. Sotalol is for atrial arrhythmias, and you need to connect it in your mind with QT prolongation, a dangerous change in the heart's electrical rhythm. Then you have flecainide for even more serious ventricular arrhythmias. And get this, its major side effect can actually be making the arrhythmias worse. It just goes to show how carefully these meds have to be managed. Now, this one is really unique. Corlenor, or ivabradine, is for a very specific kind of heart failure patient, someone whose heart rate is just way too high, even on other meds. It works on the heart's natural pacemaker, the SA node, to directly slow things down. A really weird side effect to remember for the test is that patients sometimes report seeing flashes of light or visual brightness. Okay, let's talk about the blood itself. This category is absolutely critical, you guys. We're looking at anticoagulants, people call them blood thinners, which slow down the clotting process. And then antiplatelets, which stop platelets from clumping together to form that initial plug. Two different jobs. First up, the heparins.
You've got the classic injectable heparin used all the time in hospitals to treat clots. Then there's Lovenox, or enoxaparin. That's a low molecular weight heparin. It's more predictable, and it's often used to prevent clots like a DVT. For both of them, what's the #1 risk you have to remember? It's bleeding, always.
And here are the newer guys, the direct-acting oral anticoagulants, or DUACs. The key here is knowing exactly what they block. Pradaxa, or dabigatran, directly inhibits thrombin. Eliquis, or apixaban, inhibits something called factor XA. They're used a ton for preventing strokes in patients with atrial fibrillation, or AFib. And just like the heparins, what's that primary risk? You got it, bleeding.
Now for the antiplatelets. Remember, these don't mess with the clotting factors. They just stop the platelets from getting all sticky. A really important one to know is Effient, or prasugrel. It's used to stop clots from forming inside a coronary stent right after a heart procedure. And if you're telling platelets not to do their job, what do you think the major risk is? Once again, it's bleeding. All right, we're on to our last quick category. I'm sure you know your statins inside and out, but there are a few other high-yield cholesterol drugs you need to recognize, and these work in a totally different way. So meet the bile acid sequestrants. The mechanism here is super straightforward. These drugs, like cholestyramine and cholecephalin, they literally grab onto bile acids in your gut, so you just poop them out. Your body then has to use its own cholesterol to make new bile acids, which lowers your cholesterol levels. And that mechanism perfectly explains the main side effect. If you're binding things up in the gut, you're probably going to cause some constipation.
And there you have it, a super fast review of all the key classes. We blew through ACEs and ARBs, calcium channel and beta blockers, diuretics, antiarrhythmics, the super important anticoagulants and antiplatelets, and we finished up with bile acid sequestrants. That is a huge chunk of the cardio and hemo drugs you need to know. And that wraps up our high-yield review of the top cardiovascular and hematologic drugs. Seriously, these meds show up all the time on the PTCB, so keep reviewing them until they feel like second nature. If this helped you study smarter, do me a favor and make sure to follow, subscribe, and share the PTCB Prep Guide with anyone else who's grinding for their certification. Your support really helps us keep making this kind of simple, focused content. Thanks for listening, and keep pushing toward that pass.